This is a CT scan of the abdomen and pelvis without intravenous or oral contrast, and it has interesting findings. The first thing that we notice is the dilatation of the renal collecting system bilaterally. These are dilated calyces. And you see also dilated calyces and renal pelvis on the left side, as well as dilatation of the ureters. The ureters should be difficult to see, seen as tiny threads or dots. Here they're bilaterally dilated. You could follow the tubular dilatation of both ureters on each side going all the way down. Before proceeding, you have to think about distal obstruction. Many pelvic abnormalities may cause bilateral hydroureter. Now let's try to explain all the unusual appearances that we see in the pelvis. This is a distended urinary bladder. The wall of the urinary bladder should be very thin and difficult to see. However, there is near circumferential thickening as you see on the other side. The thickening of the urinary bladder extends inferiorly to involve the outlet at the junction with the urethra. An important observation is the presence of a normal appearing and a normal sized prostate gland. So the abnormality that's leading to obstruction is not related to the commonly seen prostate hypertrophy, it's rather related to the abnormal outlet here. The other interesting finding that we see is the presence of two different hyperdensities inside the urinary bladder. There's this relatively less dense material within the urinary bladder that's separated from the wall. And as we learned from previous clips, acute blood clots appear relatively hyperdense without contrast. And this is consistent with an acute clot in the urinary bladder due to the patient's hematuria. The other density that you see here is very dense and comparable to bone, so it contains calcium. Once you see what looks like a calcific density, it's always useful to change to a bone window for better appreciation. This is the abnormality as seen on the bone window. So it's definitely calcific, it's very well defined, and it has this peculiar appearance of different internal layers. Even though the size is large, this is a classic appearance of urinary bladder stones. The reason this appears like this, a lamellated appearance, is because these layers deposit over time. Now let's try to explain this unusual structure here. So this is a well-defined abnormality that has internal fluid content and is continuous with the urinary bladder. This described appearance is consistent with a urinary bladder diverticulum. Now everything is starting to make sense. Although you don't have an enlarged prostate, you have multiple features of obstructive uropathy. There is thickening of the urinary bladder wall that's involving the outlet, associated internal stone and adjacent hematoma, a secondary Pulsion diverticulum due to chronic pressure and obstruction, and back pressure leading to bilateral hydroureter and hydronephrosis. The major concern here is a neoplastic process involving the urinary bladder wall and leading to all of what we described. There is a differential diagnosis for circumferential or near circumferential thickening of the urinary bladder. However, with such an appearance, the major consideration would be a urothelial tumor, or what we used to call transitional cell carcinoma. The definite way to go about this is to do cystoscopy and sample the tissue here. However, you could further evaluate this with contrast. This is the same patient after giving intravenous contrast as viewed in the portovenous phase. Remember that a portovenous phase is obtained about 60 to 70 seconds after giving intravenous contrast. And now you could clearly see the heterogeneously enhancing thick urinary bladder wall. What happened in the interval between the pre and post-contrast study is that a Foley catheter with this balloon being inserted, And that explains why the urinary bladder appears more collapsed compared to the unenhanced study. It's also interesting to notice how the diverticulum that's connecting to the urinary bladder has collapsed after inserting the Foley catheter. Since you're almost sure that you have transitional cell carcinoma, try to look for local extension outside into the fat. Also try to decide if you think this abnormality invades adjacent structures such as the prostate or the seminal vesicles. And try to look for lymphadenopathy, which is unfortunately seen in this case, such as those retroperitoneal lymph nodes adjacent to the vessels. Just to make it more apparent to the less experienced viewer, here I highlight the aorta in red, the IVC in blue, and the lymphadenopathy in green. If you're seeing this case on call or you have to protocol the case, it's advised to do a delayed scan to fill the urinary bladder. So a delayed scan is done a few minutes later, usually 3 to 5 minutes after giving intravenous contrast. With that, you give time for contrast to excrete into the renal collecting system, and this is the renal pelvis and the ureters being bright with contrast. Look very carefully at the renal collecting system, since if you have a urothelial tumor somewhere, there's a very good chance you have multiple of those. The numbers differ from one paper to another, but there's about a 3 to 4% chance of having TCC above if you have a tumor in the urinary bladder, and about a 30 to 40% chance of having TCC below if you have it higher up in the collecting system. The theory is that TCC above could shed tumoral cells which could extend all the way down and involve the lower collecting system. No matter what theory or numbers you use, the teaching point is seeing TCC in one area prompts looking for it in other areas as well. This is a sagittal image showing the Foley catheter with the balloon and the thickened urinary bladder wall with the stone within. And this is a coronal image to better identify the tubular and tortuously dilated renal collecting system. The urinary bladder lesion was scoped and biopsied and proved to be a transitional cell carcinoma. So we learned from this case that if you see bilateral obstructive uropathy, make sure that you don't have a pelvic cause for that. A common reason to have obstructive uropathy in elderly males would be prostate hypertrophy. However, look for other causes. An important cause would be urothelial tumors of the urinary bladder. We saw also multiple features of obstructive uropathy in the form of dilatation of the urinary bladder, a diverticulum, an internal stone, and back pressure effect leading to dilatation of the ureters and renal pelvis. We also learned that stones may have a lamellated appearance, and we discussed the utility of viewing the scan with contrast and doing that at multiple phases. In earlier phases, such as the arterial or portovenous phase, the renal collecting system is not filled with contrast, and that's why it's useful to do a delayed acquisition after a few minutes to see filling of the renal collecting system and make sure you don't have filling defects. We also revised the CT fact of acute hematomas and blood clots being slightly hyperdense even without giving contrast. From a practical point of view, when you see this lesion, cystoscopy and tissue sampling is recommended, but always make sure you don't have multiplicity with TCC. Thanks for watching. We really appreciate your comments. See you with more cases later. This is an interesting case that has multiple findings and a few very good teaching points for radiology residents. The patient has bilateral pleural effusions, and a small amount of pericardial fluid. The intra-abdominal fat, which should be as clean as the subcutaneous fat, is very dirty and stranded. The omental layer, which is located anteriorly, is stranded by soft tissue densities. The fat of the mesentery, which is attached to the small or large bowel loops, is also stranded and has multiple soft tissue densities. The peritoneal lining of the abdomen, such as the peritoneal reflecting over the diaphragm here, is also extremely thickened by soft tissue abnormalities. This is the liver here, and this is the thick peritoneal reflection. The thickening may be better appreciated as you see on the coronal images here, and here as well. The intra-abdominal abnormality is also manifesting as multiple bilateral homogeneous lesions within the kidneys. This is a close-up to show you one of the largest lesions in the left kidney. There are multiple similar lesions of smaller size as well. Compare that to the normal enhancing cortex. The right kidney is not spared as well. You see multiple similar lesions. On this delayed phase, the bilateral renal lesions are even more clear. Note how the liver is enlarged and displaces the bowel loops inferiorly. This is even better appreciated on this coronal image, as you see the longitudinal measurement of the liver is enlarged. The abdomen shows this extensive soft tissue abnormality that's involving both the small and large bowel loops. For example, the largest abnormality here involves the right side of the colon. In particular, it involves the cecum. And here you have involvement of the small bowel loops as well. In a previous clip, we talked about how you could track the distal small bowel loop as it becomes the terminal ileum and goes into the cecum. And as you could see here, this is a very abnormal distal small bowel. The terminal ileum here is very thick. And there is an extensive thickening of the ileocecal junction, which is difficult to appreciate as it goes into this thickened cecum. A very interesting finding is that despite this extensive bowel abnormality, the lumen is not completely compressed. And there is no secondary associated proximal bowel obstruction. This is even more clear in the terminal ileum, which is extensively thick, yet it has an internal lumen that's fluid-filled here. And instead of seeing luminal narrowing of the ileum, you see luminal dilatation. This paradoxical luminal dilatation is called aneurysmal dilatation of the bowel. To complete the case, you could see thickening of the peritoneal reflections in the pelvis as well. And this thickening even extends to involve the peritoneum lining the left inguinal hernia. To summarize the findings, the patient has bilateral pleural effusions, pericardial effusion, hepatomegaly, multiple soft tissue masses involving the bowel, such as this one here involving the stomach, multiple homogeneous bilateral soft tissue masses of the kidneys, and abnormalities of the omentum, mesentery, and peritoneal reflections. The overall appearance is consistent with the neoplastic process, and the main categories would be metastasis versus lymphoma. Many features favor lymphoma in this case. First of all, the patient's age and the lack of a primary malignancy would support lymphoma. The multiple bilateral homogeneous soft tissues of the kidneys are more likely to be lymphoma than metastasis, which is even more rare. The presence of these intraperitoneal soft tissue masses, which are consistent with lymphadenopathy, could be seen with lymphoma or metastasis. However, if this were to be metastatic, there are two unusual features. Metastatic deposits of large sizes are classically necrotic in the center, and this is not the case here, and that favors lymphoma. Second, if you have involvement of the bowels by this kind of metastatic process, you'd expect to see obstruction. To the opposite of that, you see aneurysmal dilatation of the bowel loop, and this is a sign that's highly suggestive of lymphoma. The reason that lymphoma leads to this, that it's a relatively soft tumor that invades the neural elements in the wall and leads to the secondary dilatation. The case was a proven lymphoma after all, and the patient received chemotherapy. The story does not end here. Let's look at the follow-up CT. So this is the follow-up CT about 20 days from the initial scan. And as mentioned, this is after receiving chemotherapy. You see here there is a remarkable response to treatment, which is not surprising with most lymphomas. There is improvement in the hepatomegaly. There is also a reduction in the peritoneal wall thickening. As you go lower down, the renal involvement is much more better with residual masses that are smaller in size. The intra-abdominal masses involving the peritoneum and the bowels is much better than before, including that we saw in the stomach. And there's a much better appearance of the lymphoma involving the large bowel as well. Now let's concentrate on the right-sided colon, because here's where the case becomes even more interesting. The right colon is not totally normal, but you could argue that this is part of the residual lymphoma that we saw 20 days ago. However, when you look more carefully, you'll notice that the density of the mural thickening is very low, suggestive of edema. You'll also notice that the surrounding fat is very stranded, and there is some fluid around it, suggestive of an inflammatory condition. And this should ring a bell, especially that the rest of the lymphoma has improved significantly elsewhere. Notice how there is fluid within the colon here. There's a mucosal enhancement, then edema, then enhancement outside. As we mentioned before, this layered appearance or target appearance is highly suggestive of acute inflammation and edema. If this were to be lymphoma, you'd expect it to have soft tissue density unless it became necrotic after treatment with chemotherapy. At this point, you have to ask the clinician about more information. When we did that, we discovered that the patient is extremely neutropenic after chemotherapy, has fever, tenderness, and abdominal pain. The imaging features and the clinical scenario is consistent with acute inflammatory changes. And this condition is called neutropenic colitis, or more famously, typhlitis. So typhlitis is acute inflammation of the colon, and the condition may less commonly involve the right-sided colon or other parts of the bowels. This is a condition that's classically seen in patients who are neutropenic after chemotherapy for hematological malignancies or transplantation. The reason this happens is not totally clear, but drug toxicity and microorganisms may have a role. It's important to remember that this is a life-threatening condition, since the risk of perforation and associated complications is very high. Again, remember typhlitis. Let's summarize what we learned from this case. First is lymphoma is a very common condition that could involve multiple organs. Whenever you have lymphoma, the differential diagnosis could include metastasis, and the appearance may overlap. However, lymphoma is more typically homogeneous despite large sizes and could be associated with the classic aneurysmal dilatation of the bowel loops rather than obstruction. And don't forget to include lymphoma as an early differential diagnosis for multiple bilateral homogeneous soft tissue masses of the kidneys. Remember to check the omentum, the mesentery, and peritoneal reflections on every case, since malignancies such as lymphoma could involve these structures. Lymphoma, in many cases, could be highly responsive to chemotherapy. And finally, if you see inflammation of the right-sided colon, in particular the cecum, in a neutropenic patient, you should raise the possibility of typhlitis. When that's the case, call the referring physician immediately, since typhlitis is a medical emergency. That's it for today's case. Thanks for watching. Don't forget to support us on all social media platforms. See you later with more cases. This short clip is mainly to show you the major role of cardiac CT in assessing the coronary arteries. So as you see, the images here are magnified to enhance the cardiac structures, in particular the coronaries. And all the cardiac structures are clearly seen with no motion artifacts. Now, the reason we were recently able to image coronary arteries by CT is with synchronizing the images with ECG. By doing that, you could target specific parts of the cardiac cycle to eliminate motion artifacts. And this gives you these beautiful images that you could see in different planes. For example, this is an axial plane. This is a 4-chamber plane where you could see all the chambers in one view. This is a 2-chamber plane where you see the left ventricle and the left atrium. And this is a short axis plane similar to what you see with nuclear medicine imaging, where the left ventricle looks like a circular structure or like a donut. You could even look at more exciting stuff by performing 3D imaging of the heart and removing or putting on layers. Looking at all these different reformats, you could tell how powerful this modality is. One of the things that I need you to know that this is called a cardiac CT, where you could look at different structures. In simple terms, you could look at big structures, or what we call a structural study, to look at the ventricles, the atria, and others. Or you could dedicate your exam to look at the coronary arteries, which is the most common indication. So remember, although that coronary artery assessment is the commonest indication, you have lots of other indications with cardiac imaging. It's not only about coronary arteries. In this clip, I'm going to concentrate on the main reason why we would do the coronary arteries by CT. Here you have an example of a right coronary artery which is very clean without atherosclerosis or stenosis. On the other side, you have the left main coronary artery and a left anterior descending coronary artery, very nicely seen as well. However, these axial, 4-chamber, short axis, or other reformats are not the only way to look at the coronary arteries. The correct way to look at those vessels is to look at them in a view that simulates what the cardiologist sees, which means that you have to look at these vessels in a way that's similar to the coronary cath. And this is what we're talking about. This is called a curved multiplanar reformat. The vessel is reformatted in a way that simulates the cath appearance, and you could rotate back and forth to check for plaques and stenosis. The main teaching point of this case is what I'm going to say next. Many people get deceived with the beauty of these images and think that cardiac CT may be optimal for everybody. However, that is not the case. Cardiac CT could be a very common examination for certain patients. For us to understand that, I'll tell you that cardiac CT is extremely sensitive to plaque. Meaning that if you have even minor plaques, that may be overcalled and may exaggerate stenosis. In other terms, this could lead to an increase in the false positive results. You'd call stenosis where it's not there. On the other hand, if you have a normal study, you're sure that it's normal. And that's what we call in statistics a negative predictive value, which means how much trust you're going to put in a study if it tells you that it's negative and normal. Given the high sensitivity of CT, the negative predictive value has proven to be around 95 to 100%. By putting all this together, you understand that CT is great in confirming normality rather than confirming abnormality. So the right indication to do a coronary CT is to do it in a patient where the likelihood of coronary artery disease is low or intermediate. In other terms, this study should be done in a patient where the clinician thinks the coronary arteries are normal and wants to confirm that. Apart from a few exceptions, doing such an examination in a high-risk patient such as an old patient, diabetic, hypertensive, wouldn't be the ideal thing. Doing the exam in such a wrong patient would very likely result in false positive readings. A good coronary CT practice is judged by the number of normal cases rather than abnormal cases. So if your hospital is doing coronary CTs and 90 or 95% of them are normal, you're probably doing the right thing. On the other hand, in practices where the CT results for coronaries are almost always positive for obstruction, that's probably not using the CT well. So let's revise. Cardiac CT is ECG synchronized. You could look at the heart with different reformats and 3D reconstructions. The commonest indication to do a cardiac CT is to look at the coronaries, however, you could do it for non-coronary findings. When you do it for the coronary arteries, you could look at those vessels in a similar fashion to what's done on catheter coronary angiogram. False positive results is the enemy on cardiac CT, however, it has a very high negative predictive value, which means you want to do it in low to intermediate risk patients where you want to confirm normality and not abnormality. Hopefully in future clips we'll talk much more about cardiac imaging by CT and even MR, since that's a very exciting topic. By the way, this is a patient who's 43 years old who presented with atypical chest pain, has no risk factors for coronary artery disease. His cardiac enzymes were not elevated and his ECG was non-specific, so his clinician did the CT scan and confirmed that he is normal. That's it for today's case. Thanks for watching. See you later.